Hi, this is Dr. Bob Dannenhoffer. It's March the 9th, 2021. It's March the 9th, 2021, and we're doing another of our Facebook Live events. It's now been a year since we've had our first case here in Douglas County, and it has been quite the year. We have been working like crazy over this last year in doing it. I haven't had many days off, and our team is just working round the clock to do this. I think we're really at a crossroads now. We may well be doing really well in the next few months, but there are some warning signals out there. So anyway, this is a chance for us to answer your question. We already have some really good questions in today through the Facebook questions. And that's really the best way to get your questions answered, because when we get the questions that way, if you have a long question, we can get a look at it in leisure and be sure we get the right answer. When you put them in the chat section, they have to be condensed a little bit so we don't always capture the full essence of your questions. So again, it's Facebook questions at douglaspublichealthnetwork.org, or you can put them in the chat section tonight. So as always, we start at the world level and then we move down to the local level. And so at the world, a little worrisome. We had this decrease in January and February, but now the cases are starting to rise again. The number of deaths is flat, but the number of cases now rising again, and we're starting to see cases in worrisome places. We're seeing cases in the Middle East. And the Middle East is worrisome because the areas around Israel are really still problematic. Syria, the West Bank, all of those areas are really in considerable upheaval, and those are places where the disease can spread and spread quickly. So the West Bank is just a tiny little area geographically, really not much bigger than one of the really small counties in Oregon with 4 million people there. And so with all of those people in the West Bank, the chance for this to spread very quickly is there. And in Syria, with so much upheaval due to their civil war, the concern is that it could spread rapidly there. Still seeing some places in Europe where it's really active. Czech Republic, Sweden still kind of active. The rest of Europe has really quieted down. But then we're starting to see cases still rise again in Brazil and Chile. And these are concerning because these are two countries that had a tremendous amount of disease last year. And the thought was, well, they've kind of burned it through. There's not much left. And yet we're seeing a lot of cases there that make us worry that the variants are there and that people are getting sick a second time despite having the disease the first time. The other big concern is Africa. And you haven't heard this much, but you will in the next few weeks, that Africa is a big area of concern. And the reason Africa is an area of concern is there's been very little disease in Africa. Some people say it's because we just haven't tested, but I think there just has not been a lot of disease in Africa. Because remember, this disease is usually brought in from travelers from other areas, and Africa, being a relatively poor country, has not had a lot of visitors from elsewhere. But the concern is if this disease starts to spread in some of their mega cities like Lagos or Kinshasa, it could really spread quickly. And if it spread quickly, it would likely start with some variants, because the variants are there already in the world, in the UK and Brazil and South Africa. And then it would vary even further. And so you get more and more modifications of the virus. And then this could then reseed Europe, could reseed the United States with variants that might not be amenable to the vaccine. And that is the big concern. I was on a long conference today, and it appears that some of the variants that are out there are tenfold less likely to be affected by the vaccine. Now, these vaccines that we have out there, the Pfizer and the J&J, have this really high level of neutralizing antibodies, and that's why they've been so effective. But the variants, unfortunately, are 10 times less susceptible to the neutralizing antibodies than are the original strain. So the worry is that the variants are out there. There's nothing to say we won't have more variants that are going to make it worse. So if anything keeps me up at night, it's about the variants. I think everything else is going pretty well, but the variants is really a big issue. In the U.S., our cases are flat, or I think even decreasing a little bit. Still seeing some disease in Texas, Alaska, and Alabama. My big concern in the U.S. is spring break week is coming, and I've seen some of those pictures of people gathering from around the country in places like the Gulf Coast of Texas or in Florida to do spring break and have a good time. And during that time, there's going to be a lot of inside as well as outside mixing, and could be some real spread of disease. So that's a real worry there. In Oregon, our cases continue to go down, although we've seen a little bit of a spike in the last few days, but I think Oregon cases are still low. Douglas County, our cases are also down from where we were a few weeks ago, but they're still higher than we would like. And we're still seeing more cases than we would like to see, and we're seeing them in workplaces, schools, and churches. And we're seeing some funny things, actually. We're seeing high attack rates. So we've been doing this for a year. And what we've seen in the past is that there'd be a case at a workplace and you see a couple other people get infected. Now we're seeing one person get infected and everybody get infected. So it does appear that at least the strain that's going around Douglas County does seem to have a higher attack rate than we've had before. But anyway, that's where we're at. We still do not have the variant stuff back yet. So we only have had testing for one variant, and one was positive for the Brazilian variant. All the other tests are still pending, so we do not know the results on those. I really wish I knew, but we don't. All right, so let me go through some of the questions we have here, and then I'll let you know. All right. All right, so Dee Dee says that she's 75 and she wants to know a reasonable ETA for the COVID vaccine. I'm a patient at Valley Ridge Medical. To date, they say they're working on patients 75 and above, so presumably you would be next. Our goal is to have all seniors have their first dose by the end of March. I think that's not unreasonable. We got a lot of vaccines last week, fewer vaccines this week, but we've gotten more. And so the hope is that we're going to be able to get to you soon. I don't think Valley Ridge is holding back. They've done an incredibly good job. It's just that until last week, people would say we could use 100 doses. We could only give them 30 or 40. Last week, we were close to getting people what they wanted. They still wanted more than we had. This week, we're just on the edge of doing that. So I would hope in the next few weeks it's going to get better. In addition, we are going to do a drive-through event this weekend. So this weekend we got a little bit of extra J&J vaccine and a little bit of extra Pfizer vaccine. So Pfizer vaccine, hard to deal with, so it has to be dealt with specially. It especially looks good for the drive-through event. And the J&J, which is just a single dose, we got a few doses of that. So this weekend we're going to do 500 doses of the Pfizer and 200 doses of the J&J for seniors only. So people 65 and above. And we're going to do this in a way which will allow people to sign up. The sign-up's going to start tomorrow, Wednesday at noon. And there are going to be two ways to sign up. One is you can sign up online. That's going to be far and away the easiest and the quickest, and you'll know immediately if you have a vaccine. The other way to do it is to call. One of our call takers will call you back and walk you through getting signed up. The sign up is easy, even I can do it, so that I would encourage people to go online. It's going to be through a site called Eventbrite. It's not going to be open until noon tomorrow. So if you try and do it tonight, it's going to say it's not open. It'll open tomorrow at noon, and then people can get on. We've done this in the past. It was an easy and quick sign up, and people were able to get there. So we're going to do it. We're going to do a drive-through at the fairgrounds, and we hope to get another 700 people vaccinated, at least their first dose. So that'll get us there. But again, the vaccines are coming in a lot faster now than they were before, and Valley Ridge got some delivered. I think they're getting theirs on Thursday. So the problem on these things is these vaccines come when they're going to come. They're supposed to come on Monday. Yesterday we were ready. We had somebody ready with coolers to deliver them to all of the clinics today. They didn't arrive until this afternoon. So they're going to get delivered on Thursday. So it is confusing. So Alice says, why do you send lab samples for variants all the way to the CDC instead of the local universities? Yeah. Again, another very long conference we were on, and I talked with the person at the state who's in charge of this about the complications of sending these COVID variants. I mean, I don't really care where in the world it gets done. I just want to get it done, and I want to get it done before a month. So the U of O can do this, OSU can do this, OHSU can do this, But I will tell you, it is maddeningly difficult to get them done. And so I was on a call, and there were all the top people of the state, and they said, we've got to make this happen immediately. So we've got to make this happen so we can see the variants. We're really good at following cases back one generation and forward one generation. We're pretty good at 2 generations, 3 generations occasionally, but by the 4th generation, we lose the scent of what's going on. So if you've ever done any kind of tracking or tracing or genealogy, you know the first 3 levels of your parents are easy to find, and then it gets really, really hard by the time you get to the 4th and 5th generations. So similarly with us, it's really hard for us to follow these cases out. So when we wait a month to get it, that's 5 or 6 generations out. We've almost always lost the scent by then. So you're right. So as I said to the top person in the state today, we have to be able to get these results back within 6 days. And they said they're going to make that happen. So I hear you. We had a bunch of emails back and forth about using local universities. And again, I don't care who does these. I just want the answers. So Alice says, why are the COVID positive numbers so high in care centers lately? So in the care centers, the vaccine seemed to work pretty well, but there are 3 issues. One is the vaccine did not work 95%. As we expected it to. There were still a number of people who got 2 doses and still got the disease. Although the vaccine was really quite effective, at least 80% effective, it wasn't the 95% we thought. The second thing is workers in care centers don't have to get vaccinated, and only half chose to get vaccinated when offered. So the other half of the people who are not vaccinated got infected and maybe spread the disease. In addition, a third complicated factor is that the Federal Pharmacy Partnership vaccinated everybody who was in nursing homes and thought we're done. What they didn't take into account is that new people come into nursing homes, right? So people go to a rehab center, get better, go home. Some people go to a nursing center and die, and then new people come in, or some people transfer to different ones. So there's always new entries to the care centers, and they never figured out how we would vaccinate the new people in care centers. So again, all I seem to do is be on these conferences is how to fix that problem. So why do I think the case counts in other counties have plummeted so fast? Do I think maybe that people are just not getting tested anymore? And what's different here? So I think there are 3 differences. I think one is I think we do have more testing available here than in other counties, but I think that only makes up a small rate of it. I think the second thing that happens is there's something different going on here, and I think it's probably a variant that is more infectious and spreading quicker in our county, and I think that's the problem. I think the third issue is that other places have had just a lot of other disease, so there are more people with natural immunity. I mean, our rates are high, but they're still lower than the national average. So I'm disappointed that they're at the national average. I always want to be far better than the national average. But there's something unusual going on, and it's not just in Douglas County. It's all throughout southern Oregon. So if you look at Jackson, Josephine, Coos, and Curry counties, we've been kind of the hot spot in the state, and we don't exactly understand what's going on in our areas. And I think we're going to really need the variant analysis back to figure out what is going on. So let's see. So CDC, talking about what happens when you're fully vaccinated. So there's 3 questions there, so I'll do the first one. So the CDC said if you were fully vaccinated, that is 2 weeks after the second dose of Moderna or Pfizer, or 2 weeks after a single dose of J&J, that your risk of having the disease was low enough that there were now 3 exceptions. One exception we call the grandma exception is that you're 2 weeks past the second dose. You can more safely visit with low-risk, unvaccinated folks like your grandkids. That's a great thing for grandparents, right? So grandparents really miss their grandkids, and this would give them a chance to do that. The second one is the dinner exception, that groups of vaccinated people, vaccinated and vaccinated, could meet without masks reasonably safely. And so that's the dinner exception. So you and your wife and your friend and their wife are vaccinated, you could meet together more safely with masks. And the third is the quarantine. So you've been fully vaccinated, you get exposed, You don't have to quarantine. You can just self-monitor. So those are the three. There's been some argument about that. Some have suggested that is, they said safe and not safe. And that's my argument with them. They sort of say safe and not safe, where I say really unsafe and safer, safer, safer. So really unsafe, unvaccinated, big groups in an indoor place, that's unsafe. It gets safer being outdoors. It gets safer being vaccinated. It gets safer limiting the number of households. So I think that those things are not unreasonable. Now, some people have criticized that they said that travel would be still a safe activity. I don't know what to make of that. So Paul asks a very intuitive question. How much time it takes if they only got a J&J single dose before one could be considered immune? Well, it's kind of confusing because the protection after a single dose of Moderna or Pfizer and J&J are about similar, yet you have to wait 2 weeks after the second dose of Moderna and Pfizer to be considered fully immune, but only 14 days after the first dose of J&J. So J&J will actually get you to that immune quicker, although I don't think as much. So it's a kind of a nuanced question, but it's 14 days after the single dose. And you say, thanks for getting the fair share of vaccines. So I understand there's a new verb out there, which is what happens when when you are in Bob's sights. So I can tell you, I have been absolutely relentless with the people at the state, and they know when it's happening. When, send them the measured email saying, look, we've got to do something about this, and then they just get pummeled over the next week until we get where we need to be. And my two this week are, what are we going to do when people go to nursing homes? They got to get vaccinated. We cannot allow people to go to nursing homes and not be vaccinated because we haven't figured out a way to do it. We've got to figure that one out. And the other one that I have is about these variants. I mean, we cannot wait 30 days for the variant. It only takes 3 days to do the test, right? So some tests do take a long time. So for example, tuberculosis cultures, which we've done in the past, do take 6 weeks. No matter how much you bug the lab, it still takes 6 weeks. These only take 3 days. So if they only take 3 days, there's no reason to wait 30 days in this country to get the results back. Because at 30 days, we've almost always lost the scent. In 3 days, we're still in the first incubation period, and we should be able to figure it out. So Linda says, people think that they don't have outbreaks because they aren't on the OHA weekly report. So the OHA weekly report is problematic in many ways. So the OHA every week comes out with a list of places that have outbreaks. And that report was kind of a compromise early on to report to the press which outbreaks there were, but not exposing any other kind of information. So our group talks all the time about what we'll do in the next pandemic, and one of the things we'll do is we should definitely do outbreaks in a different way. The only outbreaks that get published now are outbreaks where there have been cases, more than 5 cases in a business of more than 30 to get published. Well, I mean, there are a lot of businesses with less than 30 people. The reason they haven't published them is that there was an outbreak at a one-person shop. You'd kind of know who had the disease. So they came up with a threshold of 30 and 5 cases. And so there are a lot of outbreaks out there that never get published because they're smaller than that. The question then is, do you include, people work at the shop and then their spouse gets it. Do you include that? Sometimes it does and sometimes it doesn't. So it's very confusing. So there are a lot more outbreaks than are on the weekly report because many don't fall into the group. In addition, we don't publish church outbreaks. And we don't publish church outbreaks because of the concern that certain religions might get castigated should they have an outbreak. I can kind of see that. Imagine if it was a mosque that had it. People may think unkindly. Let's say it was a religion that somebody considered cultish that had it. People may feel really down on that. Now, it turns out that these outbreaks have affected all kinds of churches, so I don't think that's that much of an issue, but I can understand why they don't publish those. So the outbreak report on the OHA weekly thing is only really just a part of what's going on. In addition, what happens is if you have a big business or a big organization like the VA, like Mercy, like Roseburg Forest Products, you have zillions of people working in all different places, and they count that as an ongoing outbreak, even if there's no logical reason to think that people got this at work. I mean, if you have 1,000 employees who work for you, there are going to be people in your workforce who are positive. That doesn't necessarily mean you have an outbreak there, but once the outbreak is open, they keep adding the numbers, even if you have just a onesie, twosie of people who you know got it elsewhere. So the outbreaks are really miserable in the way of reporting. Unfortunately, I don't have a much better way to do it, but I think it's ugly. So James says, roughly what percentage of school teachers and staff who were eligible for the vaccine actually got it? Seems like many did, not many did with all of the school outbreaks lately. Oh, this is very interesting. So we do not record the profession of people who got vaccine. So it's a little hard to know specifically. Some states do that. Oregon does not. And so you can't know how many teachers got it. We think there were about 4,400 eligible people in the educator, childcare, and early childhood education group. We think somewhere between 1,800 and 2,100 got the vaccine. Now it's possible that people got vaccine at their doctor's office and didn't claim they were part of the 1B group. They were just their patients. But we think it was about 2,100, about half of that group. And it's interesting, we now have 6 school staff who have been, 6 school staff that have been positive, all have not been vaccinated. So, so there are a bunch of people who don't get vaccinated. So Michelle says, why is Douglas County one of the lowest vaccine rates when we're extreme category? This makes no sense. Yeah, so the vaccine rates this is the other thing that I'm working on this week. So this is my third thing that I'm working on, is that the vaccines in Douglas County are complicated by the fact that our 2 largest vaccinators are the VA and Cow Creek. So they're, if not the 2 largest, they're 2 certainly of the largest. They, because they receive their vaccines directly from the CDC, report directly to the CDC and bypass the state reporting system. Now you think the CDC could say, look, Douglas County, the VA, and Cow Creek have vaccinated this many, and they could add it to the numbers. I worked with Wyden's office last week to try and get this figured out. We think there's probably an additional 5,000 vaccines that if you added to the Douglas County numbers, we would actually be one of the higher vaccinated areas. Bruce says, can we talk about Molnupiravir, which is the new antiviral drug that is out there? So there's a bunch of exciting stuff coming out, sadly, only now about therapeutics. So when we talk about this virus, there were many different ways to attack it. One of the public health measures, wear a mask, socially distance, close down when there's high rates of disease, wash your hands, stay home when you're sick. And those are general public health measures that work basically for every respiratory virus. Those are important. The second was development of a vaccine. There was a tremendous amount of effort on there. Development of a vaccine was incredibly effective. The third was find drugs that work for this. Because if you could have drugs that work for this and made this like the flu, take some Tamiflu and you'll be better, that would be great. Our therapeutics have been terrible and I think badly bungled. So the only therapeutics that we have that work are Decadron, which is a kind of steroid. It's been out for as long as I've been a doctor, and it's very nonspecific, treats the inflammation that goes on. It does seem to be somewhat effective. There's Remdesivir, which works a little bit. It shortens your course in the ICU, lowers your viral load in a week, but in terms of really making this go away, it's not great. Then there's the convalescent plasma you take from people who have the disease. I think in the last few weeks it's shown not to be effective at all. There's the monoclonal and polyclonal antibodies that may work a little bit, but they're hard to give and they've not been as great as we would expect. if you watched 60 Minutes over the weekend, there was Luvox. And I think I was the first person to talk about this because what they talked about was a racetrack where they had a lot of people have the disease, and this doctor heard about this study about Luvox and gave it, and he had good results and whatever. The trouble with that Luvox is that study was done last August, 6 months ago, and we still don't have the follow-up studies we need to know where the Luvox really works. That is criminal that we haven't done better on this, because this disease has an incubation period of a week. The way they did this study was, as I've told you, is they found people were diagnosed with the disease. They gave them a bag that had some stuff in it, thermometers and whatever, but then had some pills and said, take the pills in this thing. And then they followed them. Some they gave placebo, some they gave Luvox. And they found that none of the people who took Luvox went on to be hospitalized or get sicker. Certainly that's what they found at this racetrack. They had something like 65 people who took the Luvox, none got sicker, 45 didn't. They had a bunch of hospitalizations and deaths. So it did look like it worked. But that I still can't tell you definitively that it works or not is, to me, really disturbing. We've spent a lot of time on ivermectin and hydroxychloroquine. Maybe they work a tiny bit, but not really very much. So this week came out these new antiviral drugs. So these new antiviral drugs seem to be great. These new antiviral drugs work great in the laboratory. And so they work great in the laboratory at stopping the spread of this virus, like there are a lot of other antiviral drugs. Zovirax that you might take for chickenpox, other antivirals like you'd use for HIV that are incredibly effective. The new antivirals for hepatitis C, incredibly effective at bringing this down. And we've had really not that much work on antiviral drugs. Imagine if you had an antiviral drug that was as effective as Tamiflu is for the flu, as acyclovir is for chickenpox, or as many of the HIV drugs are for HIV. This would be really different. So it would be, you got COVID, that's bad, take this antiviral. The chance of you getting really sick is really low, in which case this disease would go from being really a worldwide catastrophe to being sort of a ho-hum disease. So I'm really excited about these drugs. The problem is that molnupiravir, which is really hard to say, is only in phase 2 trials. So to get phase 2, then you have to get that done, then you have to go to phase 3, then you have to get that done before it gets approved. And that's the problem. Even if everything went perfectly, it's 6 months until this drug is on the market. That to me is really disturbing. The good news with Luvox, it's already on the market, it's already been approved, already been found to be safe and effective for obsessive compulsive disease, so it may be easier to use. So I'm really looking forward to better studies on Luvox. But if we as a country really put our minds to this, we could have known the answer on Luvox, positive or negative, and I don't have any vested interest in this, by September. And think of all the disease and all the heartache we could have saved had we done that. And I think as a country, we have to be really down on ourselves for not being better at this. Sorry. So Veronica says, are schools supposed to let kids come to school with a cough? No. Really, if you're sick, you should stay home. There are a couple exceptions. Kids who have a well-documented chronic cough condition like cystic fibrosis, yes, they're allowed to continue to go to school. Or kids who have well-documented asthma. However, it's so hard to separate out asthma versus COVID. Kids with a cough, anybody with a cough, should stay home. So Cheryl says, do I know when the vaccine will be available for 60-year-olds? Well, Oregon's next step after we get through those 65 and above is to do those 45 to 65 who have underlying conditions and other high-risk people. It's very complicated to describe, so I'd have to go to the OHA website. But I think for 60-year-olds without underlying conditions, I don't think you're going to be eligible for a while. So Casey says, do I have concerns with people not wanting to get the vaccine in Douglas County? Yes. So again, those half of the people in the nursing home who did not get the vaccine, and the percentage of teachers, and I don't know what that percentage is, but certainly a third of that group of early learning early childhood education and teachers didn't get the vaccine. And that really worries me because those are the people that can bring disease into nursing homes. Those are people who can bring disease into school. And so those people should get vaccinated. I would have hoped that among healthcare institutions, among teachers, that we would have had a nearly 100% vaccination rate. We're not even close to that. So Tiffany says, how long after exposure do symptoms occur? So we've discussed this before, but let's say it's the 1st of March and you get exposed. So you go to a party on the 1st of March, there's somebody else there who's either sick or otherwise contagious, and you're exposed on the 1st of March. On the 2nd of March and the 3rd of March, you feel fine, and any test you do is going to be negative. By the 4th of March, a well-conducted PCR might be positive. By the 5th of March, a PCR is likely positive. By the 6th, but a rapid antigen test is negative. By the 6th of March, you might begin to have symptoms, and a PCR is likely to be positive. By the 7th of March, you're very likely to be symptomatic if you're going to get symptomatic, and both a PCR and a rapid test are going to be positive. So in the first few days after exposure, you may have no symptoms and a negative test. So we see this all the time where people says, oh, I went to a wedding over the weekend on Saturday, and on Monday we got a call from the bride that somebody at the wedding was positive. Actually, we've had this situation here. Everybody runs out and gets a test, and they're negative. Say, oh, I'm good. I have no symptoms, my test is negative. Well, at 2 days, your test is never going to be positive, and you're not going to have symptoms. So it's good, certainly good that it's negative at 2 days, but it doesn't tell you much. You really need to wait 7 or 8 days after the exposure the next weekend to get tested and see if you have symptoms. So Dale says, given the variants, is the CDC jumping the game by telling those vaccinated that they can gather without masks? Well, we'll see. So, here's the story with the variants. Either the variants are going to be scientifically fascinating but clinically unimportant, in which case those of us who've been worried about the variants will have been worried for nothing. And there's some reason to believe that that could be the case. So, for example, the UK, where the UK variant was very prominent, and South Africa, where the South African variant was very common, both had a peak, and their peak is coming down. So it may be that with traditional measures, you can do this, and the variants will be interesting but not important. On the other hand, the story from Brazil is very worrisome, so I don't know. So this is going to be the big question that we do not know the answer to. And if you ask me back in 6 weeks, I'll let you know what the right answer was. Right now, I think it could go either way. Right now, the variants could be interesting but not that important, or the variants could really be absolutely devastating. I think we'll know 3 weeks after spring break, because spring break is the perfect spreading event for variants, right? People coming from all over to different places. So if you look at Corpus Christi, if you look at the beaches in Florida, it's not like everybody from Ohio goes to the one beach and everybody from Minnesota goes to another beach. Kids and young people who are very efficient spreaders are going to be coming from all over the country, spreading it in those areas. And we think it'll spread quickly because when we look at, for example, college fraternities, which are like spring break in one house, the spread has been incredibly fast. So when we look at what's going to happen at spring break, we'll see. So in 6 weeks, I'll let you know. So Tanya says, do you see us moving out of extreme next week? Could be. We've had a fewer number of cases this week, and we could go down. So Patty says, my 80-year-old mother got the vaccine, had a bad headache and low-grade fever. Is this normal? So headaches, low-grade fever, extreme fatigue, very common after the vaccine. Typically, it peaks on the 2nd and 3rd day. So you get the vaccine on a Friday, Saturday, and Sunday. You have the symptoms. Typically, on Monday or Tuesday, you start feeling better. However, you could have a headache and low-grade fever from something else also. And so we typically say that if these symptoms are somehow out of character, for example, you might have a headache and low-grade fever, but if you also now had urine troubles or diarrhea, that wouldn't be likely from the vaccine, and you should get looked at. Or if the symptoms were getting worse on, let's say you get it on Friday, on Sunday or Monday, that would be unusual. Usually it should be the worst the day after. So if this is not exactly right, you might get checked. So Tammy says, is there any way to request the J&J vaccine? We just got a little bit of J&J vaccine, and we were told these were for special populations. And so we're going to be using those for the special populations. So I don't think there's any particular way. Now, again, this weekend, we're going to be doing some J&J. We have just 200 doses of J&J to do that with. So yes, you could, if you were otherwise eligible, you could sign up this weekend if there is that. We're generally not using J&J except for those special populations. This vaccine is easier to use because it's just single dose. So you could imagine somebody who's homebound, it'd be much easier to just go out the house one time rather than two. Or if you were going to do some kind of other special population that might be more mobile. So for example, once we get to seasonal workers, we think the J&J would be an ideal vaccine for seasonal workers because it's not, they may be picking blueberries this week and apples the next. So we think that would be great. So Michael says, why the growing percentage for herd immunity was 60, 75%, now it's 80 some odd percent. So it's a complicated formula. So the amount that you need for herd immunity is a mathematical formula of 1 minus 1 over the reproductive number. And so that if you had a disease with a reproductive number of 10, it would be 1 minus 1 over 10, which means that 90% of the people would need to be immune to prevent the disease from spreading. That's a really high level. If you have a disease like the flu, it has a reproductive number of about 1.3, it's 1 minus 1 over 1.3, which is a relatively low number. So if you get 60% of the people immune to the flu, it's not going to spread. This disease originally had a reproductive number between 3 and 4. We think now, especially the variants are there, that the basic reproductive number could be 4 to 6. And you can see as that number gets higher and higher and higher, you need to get more and more people immune to keep this from spreading. Now, you don't need to get all the way to herd immunity to prevent this from spreading much. So there's the basic reproductive numbers, is what happens if you don't do anything. But masking, social distancing helps to bring that number down. So that's the RT, which is the reproductive number at any one time. And Oregon's reproductive number has, for the last couple of weeks, been less than 1, meaning the disease is not continuing to spread. Actually, it's slowly contracting, and that's a good sign. And so we'll see what happens. Again, the big wild card here is the variants. And I think it is equally likely that these will be scientifically fascinating, but clinically unimportant. Vaccine will still work. Public health measures will work, and we'll say, yeah, we worried about nothing. And I think the other possibility is that it's going to be really, really worrisome. What's especially worrisome is Africa. Because if now this spreads widely in Africa, and now you have new variants, that's a real headache. So Chelsea says, how are other counties downgrading risk? Well, other counties are doing kind of what we're doing, but they've not seen the big spreads like we have. And when I talk to my colleagues in other counties, they're not seeing the tire shop that starts with 1 and then has 10, the bank that starts with 1 and then has 15. They're not seeing that kind of spread like we're seeing here. So I think there's something unusual going here in Douglas County, and it may be a variant. It may just be bad luck. I mean, that bad luck can explain a lot, but it's a little bit confusing. So Patty says, will it be safe to have a second shingles vaccine at the end of March after getting the COVID vaccine this week? So when they did the studies, they asked the study participants not to have a vaccine 2 weeks before or 2 weeks after any of these study vaccines, and that was smart. Imagine if you had the vaccine and then had a tetanus shot in 2 days and then had a big swollen arm, it'd be hard to know if the big swollen arm was from this vaccine or from the tetanus vaccine. So they asked people to separate these by 14 days. Now, there's no immunologic reason to think that this would be dangerous, but that's the way they did the study. So we're asking people to separate these vaccines from other vaccines for 14 days. So as long as it's 14 days between your second shingles shot and your COVID vaccine, you should be fine. All right. So Raman asked a question about comparing COVID risks. So if you could maybe put the clarification on the question, because I don't get it the way it's been extracted. So Jessica says, when could we go without a mask in Douglas County if fully vaccinated? Well, so the CDC suggested if that you were in a group of people, all of whom were not vaccinated, that you could safely go without a mask. However, since you don't know what the vaccine status is when you're at the restaurant or at the grocery store or whatever, we're recommending that people continue to wear masks. So overall, when are we going to be able to stop doing this stuff? Well, once we get the disease down to, I think the number is 1 in 100,000 per day. So when we get down to 1 or 2 cases a day, which is where we were at for a bit, then we can probably get rid of these other precautions. But Oregon is still at 6 per 100,000 per day, so we've got a little bit of time to get this down. The vaccine is clearly our way out. But remember, vaccine does a few things. The first is it prevents bad disease in those people most likely to get it, and it seems to be very effective at that. That's why we went with nursing homes and older people, people who work in healthcare first, so that we could do that. But the people we've vaccinated so far are not going to do very much to change transmission, because the people we've done are old people in nursing homes, and for the most part, they're getting the disease. They're not really spreading the disease. Or healthcare workers who are getting the disease, they're not really spreading the disease. The people who are really spreading the disease right now are young workers. They're the 35-year-old person who works at the tire shop or at the bank or somewhere else. And they're the ones who are spreading this. It's going to be a long time until we get down to the 35-year-olds. Yeah, Clover says, is there any consideration of the state for changing levels of closure? It seems like if congregate care cases were treated differently, we might not have moved to extreme. So we had enough cases during the time that we moved to extreme that taking out any one source, schools, congregate, churches, workplaces, wouldn't have changed it. However, other counties were treated differently. So today was the time where it was announced on the movement, and there were a couple of counties that should have moved back to extreme. They were given another 2-week grace period. It's a little stinging because we were not, right? We could have been given a 2-week grace period and we were not. So it's a little galling that happened, but that I have to get past. So questions about spring break. So spring break typically happens, last half of March, first part of April, sometimes related to Easter, but increasingly related to just time of the year. So for example, in Oregon, it's not related to Easter, it's related apparently to the 25th of March. So spring break always contains the 25th of March. Yeah, so Nancy says, I mentioned about spring break, I'm worried about people coming for work from other countries. Yeah, I think we have to be worried about people coming from other high-risk countries. And clearly the highest risk country now is Brazil. I don't think we have a lot of migrant workers from Brazil, but we do have people who have professional businesses in Brazil, or people have family in Brazil, so I do worry about that. Mexico's rate of disease is relatively low at this point, so most of the migrant workers who come to the U.S. are coming from Mexico. Actually, what we saw in the past was that people didn't get this in Mexico, they got it in California or Washington. So the Yakima Valley and the California valleys is where people got it. We did not see that. We did not see any case that we thought came from out of the country. It all came from in the country. And again, migrant workers had a lot of disease last year. They tended to travel in long distances in enclosed spaces with a lot of people in a car or a truck. So you could imagine either going to the fields or back or moving from one area to another. These are a lot of spreader events. The other thing that we saw is that many of the people who were these seasonal workers met up once a year at a farm, and there was a lot of reunion-like stuff occurring at these places, shared meals, hugging, and whatever else that we thought were real risks for spread. We need migrant workers or seasonal workers, although many of the local farms are really great at hiring local people to do this. During the surge times, there really do not seem to be enough local workers to pick berries, prune grapes, do the other kind of things that we do. And so seasonal workers are really important. When I've talked to some owners of these businesses, they said, well, I'd love to hire local people to do this. There just aren't enough local people who are going to work like crazy for 6 weeks, picking or pruning or doing the kind of things that they're doing. And that is probably correct. So Robin says, to clarify, in the hospital, is one safer than the other when considering surgery in May? I don't think you could say that. The hospitals are all really quite safe. They're all really quite safe. We can only find a couple of cases that we think where people might have gotten the disease at the hospital. In most cases in the hospital, these were workers of the hospital who got disease in their outside lives and then came to work at the hospital, and they got part of the hospital outbreak, or patients who got the disease doing something else and then came into the hospital. So we had one case that our case investigators will know, where somebody who was on the run from the law got arrested, broke his leg, went to the hospital, and then the hospital was found to have COVID. Well, I mean, pretty hard to blame the hospital for that, and yet those are the kinds of things we see. So I would feel comfortable being at any of the hospitals. And to give you a personal example, my wife needed to be hospitalized this last year. We're perfectly good being at Mercy. Had we been at some other hospital, we would have been perfectly good from that. So one of the questions that came up earlier in the week and comes up here again is about, what about getting a vaccine after having COVID? And there are a couple of factors here. One is there have been reports that if people have had COVID and then get the vaccine, they have an exaggerated pain, swelling. Boy, I feel crummy after I get that. And again, that's not surprising. Remember, if you've had the COVID disease, your immune system has been primed to attack this. And now when you get the vaccine, your body is making spike protein. The body says, I know what that is. That's a bad guy, and sends its entire immune system to go ahead and work on that. And so there have been reports that people who've had the disease and then get the vaccine have an exaggerated response. Not serious, but miserable. There's also a study suggesting that if you've had the disease and then get the vaccine, you get such a great response even after the first dose that you might not need the second. However, still the recommendation is that if you've had COVID, that you still get the vaccine. There is a secondary recommendation that you wait 90 days after to give somebody who's not had COVID a chance to get the vaccine. So did I see a report that COVID can live on clothes for several days? Yeah, it can live on, all of these viruses are interesting in that they can stay on surfaces for a long time. In fact, they can stay on flat surfaces, on clothes and whatever. However, as a respiratory virus, we don't think that there's much transmission in that way. And in fact, the FDA was so bold as to say that they don't think there's, even though you can find COVID on food surfaces and other kind of things, they don't think there are any cases related to that. So the fact that COVID can be on clothes for several days doesn't bother me very much. So Daryl says, have we seen any outbreaks at restaurants, and why are they closed? So let me tell you about restaurants. So outbreaks only get reported at restaurants if they have more than 30 employees and more than 5 cases. Most of the restaurants in town do not have more than 30 people. So if there were outbreaks, they may have happened, but they wouldn't have been reported. The second thing with restaurants is, and with this disease, is you don't get a receipt when you get the disease, so you're not exactly sure where you get it. Well, if you if you attend a church, and we look at the other ways that people might connect it, but if they're all connected to the church, you likely got it at the church. However, restaurants, you typically meet up with people who you otherwise know. Maybe your family goes to a restaurant, or you and another couple go to the restaurant, and you may have been with that couple at times other than at the restaurant. And thus, if you get sick and another couple gets sick, it's really hard to know whether you got this at the restaurant or if you got it at the movie you went to beforehand, or the time you met and drove in the car together. And so restaurant outbreaks are far and away the most difficult because they so frequently involve close relationships otherwise. That being said, there have been a number of times where we have worried that there's an outbreak among family friends, and you ask the things that they did, and they said, we went to this restaurant, and we then met before or after, and we worry that it happened at the restaurant. And so, yes, there have been some outbreaks associated with restaurants, but again, impossible to know whether you got it in the car trip to the restaurant, whether you got it at the restaurant or got it later. There's some that we think you might have gotten at the restaurant, but you can't really be sure. And again, even if they did happen at the restaurants, unless they have more than 30 employees and more than 5 cases, they don't get reported. And we have tried to be incredibly careful not to castigate restaurants and bars for doing that. That being said, it's really the behavior that spreads this rather than at a restaurant or bar. So let's say you went to one of the nice restaurants in town and you had a dinner for 5 couples at this restaurant. That could clearly be a place of spread. However, if I just say, well, that restaurant's closed, we're going to do it at my house, and I had those 10 people at my house, it would be no more or less likely to spread at my house than at the restaurant. So what we're saying is it's the gathering behavior that causes it. So similarly at a bar, if we said, well, the bar is closed, so everybody's going to come to my house, and we're going to sit around the card table and drink beers for 2 hours and tell funny stories and do all that, that would similarly be risky. So I don't think it's the exact venue, the restaurant or the bar, which is the dangerous thing. It's the behavior of gathering with five family groups that is the dangerous thing. The state, however, can't regulate what you do at your house. They can regulate what happens in restaurants or bars, and I think that's why we went there. But again, I don't think people should say, oh, restaurants or bars are not a problem. The gathering that happens is a problem, although I don't think it's the bar or restaurant's fault. It's the gathering which is the problem, and that's a sort of a long answer. So somebody says, could the COVID test detect the flu virus? Well, no. So the COVID test specifically looks for the genetic material or the surface antigen from the COVID virus, and there does not seem to be any crossover in those tests. Now, that being said, the COVID test and the flu test are similar kinds of tests. There are antigen tests, there are DNA tests, but the stuff they're looking for is different. Oh, Bruce. So is the CDC guidance on what you do after you've been vaccinated based on studies or a public policy move to encourage vaccination? They didn't include me in the discussion, so I do not know. There's certainly some suggestion that this public policy move to encourage vaccination might have been part of it. Some of the studies, though, are there. And so the way they do these, the way we look at it is again, people think that I'm a contact or not a contact. I'm not a contact, I don't worry. I'm a contact, I really have to worry. Again, there's a gradation of risk. So if I was for a household contact with somebody with the disease, my risk would be really high. If I was a contact for 15 minutes for 6 feet, my risk is lower. If mine was 5.5 or 7 feet for 14 minutes, still not zero, but at some point we decide that the risk is low enough that you don't have to quarantine. And typically we've done that at a risk of infection of about 5%. So if your risk of infection with a known positive case is less than 5%, we generally have said you don't have to quarantine. And that's why we don't quarantine people who've been 7 feet for 14 minutes, and we don't quarantine contacts of contacts, because contacts of contacts are not zero risk, but they're less than 5% risk. Similarly, the CDC allowed people to go back to work after 7 days if they have a negative test on the 5th, 6th, or 7th day. The risk that you're going to still get positive is about 5%. So we've kind of informally used this 5% rule. So similarly, if everybody in the room is vaccinated and you have dinner or you're visiting your grandkids, it's typically the risk of giving it to them is typically less than 5%, and that's why we've done it. So I think it is based on some science, but there may be a public policy move to encourage vaccination. So for example, they did not say that if you don't have 2 vaccines, you can't fly, but if you do, you can. That would be another reason for people to be vaccinated. Some states may do this. Some states may say, for example, if you want to visit Hawaii, you have to have 2 doses of vaccine. So Robin says, any cases from the home and garden show or too soon? Well, it's too soon because remember, let's say even if on Friday there had been somebody who was incredibly infectious, again, you wouldn't expect to see symptoms until Saturday, Sunday, Monday, Tuesday, Wednesday. So even then you wouldn't expect to see anyone. But nonetheless, I actually went to the home and garden show on Sunday morning. It was very well done. They really limited the number of people who were there. They had the one-way flow, which is actually good because I sometimes miss things. I wander around, and in a way, this way, I sort of knew I could visit everybody. They had pretty good distancing. The fairground buildings are not airtight buildings, so they've got lots of space and pretty good ventilation. And they screened people before they got there to be sure you weren't sick. So I think it was pretty safe. So I would think the risk of disease there is going to be low. Is it too soon? It's still too soon, but I think the risk on that would be low. Similarly, I think the risk on other things we could do would be low. I think, for example, picnics at the park or music on the half shell could be safe. Outside, distance, those kinds of things. On the other hand, there are other things that people have talked about that I think would be dangerous. I still think big gatherings indoors, like a big indoor wedding, is a risk. We've seen a lot of cases. Other people have seen lots of cases associated with weddings. So I think that would be an outdoor wedding, probably pretty safe. Indoors, gets a little less safe. So for example, we had this wedding that was associated with a bunch of cases. It was typically people who either shared a car or were indoors together that had it. It typically was not people who just sat outdoors. All right, well, it seems like we've come up to time here, and we'll do this again. The big event is going to be this Saturday at the fairgrounds. It's going to go from, first vaccination is going to go from 8, we're going to go until 2 o'clock. We have 500 doses of the Pfizer and 200 doses of the J&J. And we're going to give those out. We're going to do the J&J between 8 and about 10. And after 10, we're going to switch over to the Pfizer. Reasons for that. And we're going to do it. This is only for people 65 and above. So this is not for other 1A and other populations. This is people just for 65 and above, because we're really focused on getting everybody 65 and above at least 1 dose of vaccine sometime before March 29th, when we may move on to the other parts. So we're really trying really hard to get as many seniors vaccinated this weekend as possible. Again, the way to sign up, there'll be 2 different ways to sign up. The first way, and far and away the easiest way if you have a computer and are the least bit savvy, and I'm kind of a dope when it comes to computers, but even I could do this, is on the Eventbrite site. We're going to publish that link tomorrow. You click on the link, it gets you right in there. It goes through a bunch of questions about your name and your age and date of birth and whatever. It then goes through the required CDC questions. It gives you the stuff to read about the EUA. And then if you want to go, press the button, and then you get an appointment. And then if you get the Pfizer, you'll get another appointment for 3 weeks later. If it's the J&J, you just need a single appointment, and that's how it's going to go. It's going to be a great event. We've got vaccinators from all over the state who are working, and this is really a joint effort of, and I'm sure I'm going to forget all the people, but the hospitals, Aviva, and the Sheriff's Department, and Servor, and the college. Everybody's going to come together to make this work. One last question is, how long does the vaccine last? We don't know. Remember, the very first people vaccinated with this were only vaccinated in the fall of 2020. And so we think that those people still have good levels of protection. We do not know how long it's going to last. Again, when I go to these conferences, I hear anyway, it should last for a lifetime because your T cells are so smart at remembering an infection they'd had before that they'll remember this even 100 years later. And there's good data on that. So there's good data to show that if you had chickenpox or the flu 100 years ago, and we test your T cells, they remember 100 years ago that you had this vaccine, and they snap to. So some people say this should last a lifetime. Other people say, well, respiratory virus vaccines typically last a year or less, so we'll see. So it's somewhere between 6 months and 100 years. I'm sorry that is a cop-out answer, but nobody really knows the answer to that. Again, big event this weekend. Look tomorrow for that link to Eventbrite. We're going to publish it on our website tomorrow at noon, not before, and we're going to have it on the county release tomorrow at noon, not before, so that people all have a fair chance at getting in tomorrow. Again, I hope to see a lot of you on Saturday. I'm going to be there doing some screening, and I hope everybody is there and everybody does well with this vaccine. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thank you so much. Bye-bye.